Welcome. I'm Linda Riddle from Main Care. We're going to give people one more minute to arrive. Okay, my clock says 11:31. We're going to get going. As I said, I'm Linda Riddle here on behalf of the Office of Main Care Services. Welcome, and we're glad you're taking the time to be with us today on HIV treatment, drug side effects, and patient profiles. This is part of a 4-part series that we're holding on HIV. Next Thursday, we'll have at the same time a session on, let me get the title, HIV resource navigation for medical and social practitioners. And the Thursday after that, so that will be November 6th, HIV harm reduction and intersection with homelessness and substance use. When you get the follow-up email from this webinar, it'll have an evaluation and links to those webinars if you're interested in those. So we are blessed to have with us today Dr. Rawlings. He is board certified in infectious disease and internal medicine. He comes to us via the New England AIDS Education and Training Center. He's enthusiastic about sharing his knowledge and helping HIV patients get better care. So I'm going to hand it over to you, Dr. Rawlings. Oh, sorry, one other thing. If you have questions that you'd like to raise immediately, use the raise hand feature. If you have questions that you'd rather have addressed at the end, put them in the chat. Okay, thank you.
Thank you very much, Linda. It's great to be back here, everyone. So last week was sort of about PrEP. Today, I'll focus more on treating HIV, some of the initial medicines, and things to do. We also wanted to have a little bit of time in here for patients that either aren't ready or are worried about treatment starting, and how to overcome some of that friction. Just to show it again, because I think a 30-minute webinar can give you a great start, but there's lots more to read about. These are sites that I love referring people to, and I still go to the National HIV curriculum for my own learning and refreshing. I have no financial disclosures. I just get paid through my clinical salary at Maine Health. But I do want to just call out, I normally like to use generic names for medicines, but there's some antiretrovirals that are so long and combination medicines that the brand name is a lot easier to use. It's often what patients know and what pharmacies use. And so I will sprinkle those throughout for simplicity and completeness. I'm starting very basic, just as a reminder. So HIV is a virus. It transmits human to human, and we really only transmit it via bloodborne or vaginal rectal exposure. For completeness, there are actually 2 types of HIV. There's HIV-1 and HIV-2. When we're talking about HIV in the United States, we're really talking about HIV-1. The tests are all set up so that they could differentiate between 1 and 2 on an initial screen. And really, HIV-2 exists outside of the United States, predominantly in Africa. There are a couple of drugs that don't work on HIV-2, so that's why we try to understand if it's there. But again, most of the United States is HIV-1 type, HIV type 1, clade B, so on and so forth, subtype M. After an infection, within days, a long-lived reservoir of the virus is established in immune cells, and pretty much we understand this to be impossible to eradicate. And that's the reason people have to take medicine pretty much for the rest of their lives. And there is always ongoing research around trying to see if the reservoir can be eradicated medically or through some other research-based mechanism. And it's been done in a handful of patients, but through a process that's too dangerous to apply broadly. So I just try to focus on reinforcing for people there is a reservoir, the virus will stay in the body, but taking the medicine, taking some sort of medicine typically every day, will keep that virus at bay. If there's no medicine, so if you have unchecked viral replication, we have an inevitable decline of CD4 immune cells, which can lead to opportunistic infections and then the diagnosis of AIDS. And we know that that occurs roughly 2 to 10 years after infection. Different people go at different rates, but it is essentially an unstoppable decline in the CD4 cells if you're not taking the medicine. When we treat HIV with medicine and suppress the virus, we halt that loss and can reverse AIDS. We can recover CD4 counts. We do that through the use of antiretrovirals, which get abbreviated ARV. And we need a combination. We know that we need at least 2. Some regimens have 3 or even 4 antiretrovirals combined into therapy. So that we get abbreviated as ART for antiretroviral therapy. Anybody who is taking ART and has suppressed their viral load below 200 copies cannot transmit HIV through sex. This is a major thrust of international AIDS organizations, HIV organizations, because it really helps people feel that they can own their own health, own their sexual health, and reduce their risk of transmitting HIV to loved ones. And so it's a key part of just kind of continuing the HIV, or reinforcing the HIV continuum. This is sort of pertinent to some of the cluster in Maine. We have not studied the U equals U paradigm as well in individuals who transmit HIV through needle sharing. We do believe that the transmission risk is incredibly low if you are suppressed on your ART. But it's not something that we have as much strong evidence about inability to transmit. So through sex, cannot transmit HIV if you're suppressed. If you're needle sharing, we still obviously recommend using sterile needles. A lot of HIV care, and I did talk about this a little bit last week, we look at the care continuum because it's unfortunately a leaky pipeline and we need to work on every stage of the step. So the care continuum for HIV starts with diagnosis. We want to diagnose everyone who has HIV. We want to link them to care. We want them after their visit to feel like they're willing to take ART and stay on it and keep coming to their doctor's appointments, keep refilling, and getting their lab work. When we get that lab work after, typically weeks to months of treatment and a new diagnosis, we can then achieve viral suppression. But we need to keep the cycle going. And unfortunately, in the United States, we actually have a leaky care continuum. We don't diagnose everybody who has HIV. After diagnosis, we haven't gotten everybody into care. And then retaining in care and keeping people undetectable or fully virally suppressed is still an area that we can do better. So we'd really like to see these numbers higher. The undetectable viral loads should really be at 100%. And so we need to work on each step along the way. And I'll talk about that today. Very briefly, just testing for HIV, just in case anybody wants to know more about it. There are a couple of options. From blood, we can send a 4th generation test. This is called the 4th generation because we've gone through a couple of different versions. And it uses a combination of antigen and antibody detection to find actually very early HIV infection. Some clinics and labs still stock a 3rd generation. That's a great test still. It is antibody only, and it can take in some individuals up to 3 months for their antibody to turn positive, which is why we sometimes prefer the 4th generation. That's commonly positive as soon as 3 weeks. But from blood, you can also send a viral load, which is going to be a PCR looking for HIV, and that can be positive as soon as something like 7 days after an infection. For patients outside of a clinic situation or wanting to test themselves, there is an oral swab, which is essentially a 3rd generation antibody test. It can be done at home. People can pick it up from their pharmacy. There are organizations throughout Maine that even will give out free kits. For any Peabody is one of those organizations. But any positive then does need to be confirmed. And so all positives on any of these tests need a Western blot or some other antibody confirmation, preferably done in a lab in order to confirm HIV. That is because there are some false positives, and I'm going to address that right now. So if you're doing HIV testing and you're doing enough of it, great. 99 times out of 100, you'll be giving negative results. We hover around a 0.1% prevalence of HIV in the United States. So So that means only 1 in 1,000 tests is positive. All initial positives are going to be confirmed by the lab, and any point of care test that is positive should have phlebotomy done so that we can get the full sort of pathway done with reflex to confirmation in the lab. It is stressful, and there's a bit of a time delay for preliminary positive, and we just recommend anybody who's got that prelim positive to wait for the confirmatory test before we jump to any conclusions. And I say that because there is a false positive rate, especially on the antigen antibody test, and it can be as high as 0.8%, which I told you 1 in 1,000 tests is a true positive. Well, 8 in 1,000 can actually be a false positive. It's a feature of the tests. We really can't make them any lower because we would lose sensitivity on true positives. And so all of those patients will get a repeat or get the reflex to the antibody confirmation, and it'll be negative if that's how we determine it's a false positive. And I just try to counsel those patients that this was good that we got it tested. We're sorry about any stress in the preliminary positive, but it's a great opportunity to talk about PrEP or something else that can help keep them from getting an HIV infection. And when a test has been confirmed positive, and I'll show some more slides on exactly all the tests that we send for a new HIV diagnosis, but if you're going to be referring the person and you do have an opportunity to get some blood before the referral, we'd love like a viral load and a CD4 count. These can help just confirm the diagnosis and stage it as well. The 3 things I like to make sure all patients who have a new HIV diagnosis to know 3 things. And I really harp on the long and healthy life that they can have as long as they take their medicine. So I'll show some data on this, but somebody diagnosed with HIV today can expect a long and healthy life. They do need to remain in care. They need to be on that HIV care continuum. They need to take their medicine and get suppressed. I also have patients who sometimes either because of like translation mistakes or just cultural things, or they read too much news, they think that they're cured when they see undetectable or, along that line. And so I do like to emphasize at that very first appointment or very first sharing of the HIV diagnosis that at the moment we don't have a cure. There's a lot of debate even in the world of people with HIV about how strongly we should use the word cure. I just emphasize that the virus will stay in their body for forever. And if they're willing to, entertain a little bit of a, mental trick, if you will, taking ART is like a cure because it basically renders the virus inert, suppressed, cannot do any further damage to the body, and they can go about and have that long, healthy, normal life that we talked about in point 1. If anyone brings it up, there are, of course, now about 6 individuals who have been cured of HIV. It gets news every time it happens because it's so rare, and each time scientists try to understand how the cure happened. Too in-depth for this conversation now, but all these patients more or less needed a form of a bone marrow transplant, something we just can't offer for the 40 million or so people living with HIV worldwide. And then I like to, for my 3rd point, bring up the U equals U message that you cannot transmit HIV to sex partners when you take your ART and are suppressed. I think this really helps people own their sexual health, their own physical health, and can kind of reduce any stigma that they may apply to themselves about their HIV diagnosis, particularly if you acquired it sexually and now this influences how you feel about your sexual health. So U equals U is an important part of that initial message. Just to show it, and you can tell patients about it too. Here's the citation from a recent paper 2 years ago now. This group looked at the life expectancy of people with new HIV diagnoses. They're comparing the drug regimens from before 2015 in the dashed lines and after 2015 in the solid lines. And what you see here is people diagnosed with a very high CD4 count who acquired HIV sexually. These are the 2 bluish solid lines here, have a lifespan after the HIV diagnosis that is almost exactly similar to the general population without HIV. So when I say long, healthy, normal life with HIV, taking your medicine, that is borne out by the data. It drops off a little if their diagnosis is more advanced in their stage of HIV, if they have a CD4 count less than 200. And that just emphasizes also why it's so important to get testing done early and often so that we catch people early. That slide was men. We do still have a small defect for women where we're not quite getting to absolutely normal life expectancy. It's still a very long life expectancy for women, for a woman today diagnosed with HIV. And I know several colleagues of mine even actively working on researching there may be differences in inflammation under sex hormones that cause this slight difference here. But still, today, long, healthy, normal life, 40 years of life can be expected after an HIV diagnosis for a woman if they take their medicine and keep the virus suppressed. So initial management of HIV, I think is the basic focus of the talk. I'm relying heavily on this great document put out by HHS, Guidelines for the Use of Antiretroviral Agents in Adults. It's basically our Bible of HIV care, linked here as well. It's a pretty long document, depending on which version you open up, but they have some really great tables. It's, I think, very well written, and it explains just everything you need to know. But I'll go through the tables in a minute. So initial steps, just a quick triage thing. Anybody who's acutely ill and has a new HIV diagnosis should probably be evaluated in the hospital. We're looking for things like opportunistic infections, particularly if we already know that they have an AIDS diagnosis based on their CD4 count. But an ambulatory patient should be connected to HIV care, ideally at the same time that they're informed of the diagnosis. So if we have places ready to provide HIV care at the same location where the patient finds out about their HIV diagnosis, that's ideal. Obviously, it may not always happen depending on a clinic situation, but giving somebody the information of where they could go for their referral will be extremely helpful. We at the Gilman Clinic, we can usually get people in within 7 days of a referral, and we try to get that really early connection to care. Here's the list of labs. I won't go into this too much, but we're staging just general kidney, liver, bone marrow function, urinalysis here. There is a genotype that's recommended. This test can be a little bit difficult to order, and if somebody's had any integrase exposure, something like if they've been on Apretude or the cabotegravir pre-exposure prophylaxis, we need to add on an integrase. But all explained in the guidelines, reasonable. If you have any questions, reach out, but we're just checking a couple things and then we can get them on ART. This is the very first table in those guidelines that again just emphasizes how important it is to rapidly start ART. First off, they recommend ART for everybody. There's no waiting anymore. There's no special populations where we wouldn't give them ART. We want to start it immediately or as soon as possible after diagnosis, and educate patients about the benefits. Things like U equals U and having a long, normal, healthy life. So that's straight out of the national guidelines for HIV medicines. This table's slightly wordy, but I'll go into these, I'll break them out drug by drug. But this is the table of recommended initial regimens for people with HIV. I'm going to talk about this medicine here, bictegravir with tenofovir and emtricitabine, as well as the alternative dolutegravir with another 2 compounds. I'll leave out this medicine for now, but there is an alternative 2-drug regimen that's available for treatment of HIV. And I just wanted to cover as well, because we've had a couple cases already in Maine, anybody who was on cabotegravir, that's the Apretude PrEP, who turns out to have HIV, either requiring it while on PrEP or they had a missed infection very early on and then develops evidence of their infection while on PrEP. We do try to give them a slightly different regimen, one that spares integrase inhibitors until we have their genotype back. So I'm going to dig into those. First off, I showed you the guidelines. It says start everybody on ART. Just to briefly mention or recognize that some people have heard sometimes we don't start people right away. That was historical. There was a time when the medicines were toxic. They weren't always well supplied, and we did wait to start ART. Today, that's all different. We now feel all patients should be treated if they want to be treated, but we should also work on convincing them that they want to be treated. We don't worry about things like adherence. Our modern drugs are very resistant to resistance. I'll talk about that again. But basically, we want to get them started. Because it's helpful to know the 2 situations where we wouldn't start ART, I just like to say them out loud, but I'm not going to go into this too much. There are 2 very specific opportunistic infections that impact the brain. You'd have to be pretty sick to have these patients typically are expressing significant symptoms, headache, fever, altered mental status. And so we do not start ART if somebody has an active cryptococcal meningitis or a tuberculous meningitis. Again, very rare. These are the sorts of things that you'd probably be sending somebody to the emergency room anyway because they were expressing symptoms of central nervous infection. But the risk here is just that within a few weeks of starting ART, there can be immune reconstitution and resultant inflammation, and there is in studies an increased risk of death in those individuals. It's still so important to start ART that we're even okay if a mistake is made, somebody started on ART, and then we find out that they had a headache a week later, we can always pause ART and treat for the underlying infection. But knowing what to look out for, and it's really just those two things, can hopefully help you feel empowered to start ART and everyone else, as long as they don't have a headache. So most commonly prescribed medicine for HIV is this compound here called Biktarvy is the brand name. It's abbreviated with this emtricitabine, tenofovir alafenamide, and bictegravir. So it's a fixed dose of these amounts of emtricitabine, which we call FTC or just F for simplicity. The wording is so big on some of these HIV medicines that doctors had to figure out a long time ago how to abbreviate it. So these are abbreviations. And then tenofovir and bictegravir. You're going to see this FTC and TAF several times over the next few drugs. It's a single tab taken daily. The prescription is 30 pills. I try to give out refills with the plan to assess tolerance, ideally within the first month. And then often, depending on insurance, we can convert people over to 90-day fills, and they really like that. The side effects that are mentioned, and it's just worth, this is the only one that I have percentages for, but people will comment on diarrhea, nausea, headache. I often encourage people to just try to give the medicine a couple more days, let their bodies kind of get used to it, and they frequently see that any side effect that they might be experiencing goes away. These are all very low numbers. It's, again, more than 50% of people with HIV are taking Biktarvy, so a very well-tolerated medicine and typically very popular. Alternative, and what a great option if somebody doesn't like the side effects of Biktarvy, is a 2-pill option. So we swap out that bictegravir for dolutegravir here, and then you maintain the emtricitabine and tenofovir. This combination is sold as a single drug called Descovy. So what they are getting is Tivicay, the brand name of dolutegravir, and Descovy. And that was in that first line table. Risks here are just that patients have to remember to take 2 pills instead of 1. And there's a very small risk, but not insignificant, that somehow only 1 prescription will be renewed if a prescription refill comes in. So we just like to make sure that it's very well documented that both prescriptions need to be renewed if there's any concern. Frankly, the side effects are very similar. Patients have reported diarrhea, nausea, headache, some tiredness or sleep problems. For the most part, same thing as before. If patients can just give it a couple of days, they may see that it gets better. Simtuza is that drug that is the option if we're avoiding an integrase inhibitor, particularly in somebody who was on an integrase inhibitor as PrEP. It's keeping that emtricitabine and tenofovir, but substituting darunavir, which is a protease inhibitor. Protease inhibitors, almost always, and darunavir is no exception, need to be pharmacologically boosted. So this medicine, cobicistat, is not active against HIV, but it's put into this single pill here to help the levels of darunavir stay high. And that's the major interaction that just needs to be observed. Cobi can interact with other medications and alter their levels. So we don't want to use cobicistat in anybody who's on a blood thinner. Not much else. There's a couple of anti-seizure medicines and antiplatelet medicines besides blood thinners, but it's worth running an interaction checker with all of the medicines. And it may lower medications such as contraception. Side effects are very similar, with rash just showing up a little bit more common in Simtuza. Last comment just on Descovy and any other medicines with tenofovir and emtricitabine. If the regimen has this is potentially active against hepatitis B. Hepatitis B was one of the labs we want to check on a new HIV diagnosis. And that's because anybody with chronic Hep B, so they have surface antigen positive and core antibody positive, they are at risk for reactivation of Hep B if they suddenly stop the emtricitabine and tenofovir. So we just counsel patients that they really shouldn't go on and off the medicine. If they do need to stop it or we're switching to an alternative, we'll monitor their HBV DNA and their LFTs if going off of the drug. Please feel free to send these patients to us over an ID if you have any questions. I'm going to talk about adherence again in a minute, but high genetic barrier to resistance for bictegravir makes us feel very comfortable about using it, even in situations where resistance is or adherence is difficult. And so the reason for this, what high genetic barrier means, is that it requires many mutations in the virus to actually be able to overcome the drug. And for sort of complex biochemical reasons, it's difficult for these to accumulate. And we just get really good, mileage out of bictegravir. We typically tell people, or I mean, I don't tell everybody this, but if they're concerned about it, it's an old saw in ID that you can take like 23 or 24 doses of bictegravir, of Biktarvy, excuse me, in your month, missing several throughout the month for whatever reason, and it's not going to be a problem. There was even a poster at this year's CROI where they actually, in Italy, let people take only 1 or 2 doses a week of Biktarvy, and there was no viral rebound over a year. I don't tell patients about this exactly. It's saved for that person who's really worried about their adherence, or they feel guilty about missing a couple of doses here or there. I just try to reduce that shame, reduce that worry, and reassure them that they're doing everything they're supposed to do. And we can monitor that with their viral loads. If anybody's expressing difficulty with adherence, ask their reasons. If they need to go off of it, it's best to just be off for a while, and then go back on. But we can monitor viral loads. Now, I'm going to talk about this in a minute. I'm running out of time, so I'm going to skip this basically, but there are clear instructions of what to do for monitoring response to ART, how frequently to check. After about a year, people just get on a schedule basically of checking a viral load every 6 months and a CD4 count every 2 years. A word about long-acting injectable ART. We have a great option of a combination of 2 antiretrovirals that can be injected either every 1 month or every 2 months, so 4 weeks or 8 weeks, at slightly different doses here. And this is FDA approved for anybody who's already suppressed. And we have treatment protocols available for people who are not suppressed, but really having trouble taking oral pills, and they want to be on the injectable. I didn't want to give short shrift to these couple of slides, so I just had a couple of comments about that patient who doesn't want to start ART. So the thing here I like to do is assess their reasons right off the bat, what's holding them up. I go back to the beginning. If they don't take ART, it is inevitable decay of their immune system. It will lead to opportunistic infections. It will lead to death. I had, throughout my training and treatment, I've a couple of times had patients who were just so avoidant of ART that we could convince them to take like prophylactic antibiotics to avoid pneumocystis or toxo or like bad candidal esophagitis. But unfortunately, we can't prevent everything that is related to AIDS. And so I'm thinking of a specific patient who ended up succumbing to a terrible lymphoma of the CNS. So we really, really can't keep you alive unless you're willing to take ART. If their concern is because of side effects, let's talk about all the different ART options. If one's not working for you, we will find another regimen. I'll show you a graph too of all the different options we have. If they're worried about adherence or maybe losing their medicine, I go back to the dosing of Biktarvy. You could take 23, 24 doses of Biktarvy a month and you'll be fine. Similar actually with Simtuza, that darunavir with the cobicistat ends up staying around for a long time after each dose. We could consider the long-acting injectable if they're worried about losing the medicine. They just come to clinic every 2 months, let's say, and get their dose, and then they're good to go for the next 2 months. If they're still not ready at the first appointment, I want to see them quickly. I want to tell them, listen, I got to get you back in here like 2 to 4 weeks. I'm worried about your health. I want to see you very back soon. We're partnered in this, but let's get seen soon. And then maybe I'll offer them some extra labs so that they could see their viral loads going up, 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 and their CD4 counts going down, down, down. And maybe that will be the trigger that'll help get them in care. And then lastly, just encourage some risk reduction, condom protection, or PrEP for their sex partners because they are able to transmit if they're not on ART. Okay, I'm at time. This is the drug chart. Great option to just show people how many different medications there are out there. But these were the three I talked about. That's Biktarvy, really small pill. Here's the combo of Tivicay and Descovy, and that's Centusa. And I made it. Did anybody have any questions? Sorry about always filling up the time, but I want to try to get it through as much as I can.
I didn't see any questions in the chat. Would anybody like to ask
I'm
a
happy to
question
stay
right now?
around. Yeah.
Yeah. Going once, going twice. Okay. Well,
Thanks,
thank you.
everyone.
Yes, thank you very much. You will all receive a follow-up email with an evaluation. Please do give us the feedback. It helps us to be responsive, and we'll hope to see you next time. Thank you. All right.